Hi everyone, welcome to today's LACNETS webinar. I'm Lindsay Judovine, the Director of Communications.
And I'm Lisa Yen, I'm the Program Director for LACNETS.
Today's webinar will be focusing on management of diarrhea in neuroendocrine tumors. Our speaker today is Dr. Shirley Paski from Cedars-Sinai Medical Center. We'd like to send a special thank you to Rich at TVP Live for making today's production possible. Before we get started, I have a few tech tips for today's webinar. For your audio, be sure the volume on your computer is turned all the way up, and also double check that the volume is unmuted on the webinar broadcast screen. For your video, you can enlarge the webinar broadcast screen by clicking the expand screen button in the bottom right corner. The full webinar video after today will be posted on the LACNETS YouTube channel within the next few days. To access our YouTube channel, you can go to bit.ly/LACNETS YouTube. We also have a video library of 100+ net videos. Also, if you'd like to ask Dr. Paski a question during today's webinar, you can do so by going to www.slido.com and enter event code PASKI. A quick reminder, our webinars are done for educational purposes only and not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. The opinions and views expressed by our speakers are their own opinions. They do not necessarily represent the opinions of LACNETS. And now I'm going to hand it off to Lisa for a brief description of LACNETS and our history.
So we wanted to extend a special welcome to those of you who are joining us for the first time. A little bit about us, as you may already know, LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. And our LACNETS team include Donna Gavin, our board member, Lindsay Judovine, who you already met, Kavya Velagapudi, our interim administrator and board member, and myself. It's a small team, but we're a mighty team. We're also grateful for the help of our advisory board. So LACNETS was originally founded by our dear friend and accomplished jazz musician and composer Giovanna Joyce Mbesi. Our mission is to provide support, education, and advocacy for all people impacted by this rare disease that used to be known as carcinoid, which is an old term for what is now called neuroendocrine cancer, neuroendocrine tumor, or NET. As many of you know, NET was made famous by Steve Jobs and Aretha Franklin, who lived with NET for many years. It's a type of cancer where people often experience delays in being diagnosed for many years, on average 5 to 9 years according to some studies. So at the time of diagnosis, the cancer has already often spread or metastasized to other organs. It's a type of cancer that while it may not be curable when it's found after it's spread, it is treatable, and because it tends to be slow growing, people can live with it for many, many years as a chronic disease with appropriate treatment. Our hope is to change the narrative from people associating this disease with famous people who've sadly passed away from the disease to a growing awareness of the more than 180,000 people living well with the disease. And we want to support you as you learn to adapt to your new normal and help you live richly and fully despite living with the disease. As many of you know, we offer a robust educational program. We have a few more exciting webinars coming up in the last couple of months of 2020. So be sure to mark your calendars for all these upcoming exciting events. Our virtual Net Cancer Day Symposium on November 7th, 2020 will be a special half-day event featuring NET experts including Dr. Dan Lee from City of Hope, Dr. Sandy Kotai from Mercy Medical, Dr. Jaidira Del Rivero from the NIH, and Dr. Banerjee from City of Hope. You're going to hear a little bit about NET research and exciting new NET studies that are happening right now, as well as learn a little bit about coping and caregiving. You'll also get an opportunity to hear from more NET patients and caregivers. We have an exciting webinar on November 17th that's dedicated solely for the high-grade neuroendocrine neoplasms. We welcome Dr. Nina Vijayvergia from the Fox Chase Center in Philadelphia, who will be speaking on grade 3 neuroendocrine neoplasms, which has been an unresolved mystery for many of us. She's going to focus on immunotherapy and speak specifically towards treatments that will help the high-grade neuroendocrine cancers. Our December speaker is Chaplain Michael Echelon from the UCLA Sims Mann Center for Integrative Oncology. He gives TED Talks, and we were honored to have him as our speaker last December as well. Michael Echelon is a gifted storyteller, and I'm always encouraged and inspired by his insights. 2020 has been quite the year, and we're getting through it together. One way we're able to get through it is through our virtual support groups that meet weekly every Wednesdays at noon. This has been a really special time for patients and caregivers to share our own experiences and learn from each other. And we also have a helpful how-to video for those that are unfamiliar with Zoom and need a refresher that will be emailed to you after you register for the meeting. NET caregivers are invited to a special space that we offer for NET caregivers only on the last Saturday of every month, where we meet just for NET caregivers to discuss our own NET caregiver-specific issues. This is a time facilitated by palliative care physician Dr. Banerjee from City of Hope, who you will hear speak at the November NET Cancer Day Symposium. We also offer a buddy system called NET Connect, where we can connect you with someone else on this journey for peer support. Some people might reach out to connect with someone else who has had a certain type of treatment or surgery your doctor has suggested for you. Others might want to talk to someone else with the same type of NET, or perhaps you just need a listening ear from someone who understands what you're going through. We want you to know that you are not alone. NET Vitals is a downloadable 20-question communication tool that highlights the vitals of your NET cancer. These are the most important things that your NET expert wants to know when they see you for an appointment. You can download and print it and fill it out before your consultation with your NET expert. This helps you get on the same page in terms of terminology and getting to know your own disease. Filling out your NET Vitals as homework to prepare you for your appointment can be empowering as you learn to speak NET and know the details of your own disease. It can also help make your appointment more efficient. The time is then better spent because it prepares you to ask smarter questions and also increases the time you have to ask questions. So your smarter questions might be questions that came up filling out your NET Vitals. And then instead of spending your time defining NET terminology, you can spend more time talking about your treatment and how to improve your quality of life. We're also thrilled to share that NET Vitals was featured in the recent conference for medical professionals called NANETS, the North American NET Society. Dr. Dan Lee from City of Hope gave an oral presentation about how NET Vitals has helped the NET community, and that was really exciting for the NET experts to hear. We've written many educational blog posts on a variety of topics, including PRRT, research, running this marathon of the NET journey, finding calm during coronavirus, and many, many more. We've also written short quizzes as a fun way for you to test your understanding of all the information and education you've been taking in. Our quizzes go along with NetRF's NetWise podcast, so if you've listened to NetWise podcast, pop over to our quiz page and take a quiz. And now back to you, Lindsay.
Thanks, Lisa. And be sure to follow LACNETS on our social media channels. We have a Facebook, Instagram, Twitter page. You can find us at LACNETS. Also a reminder, we have our YouTube channel with 100 plus NET videos. You can find that at bit.ly/LACNETS YouTube. And Lisa, I'll let you take it away from here to introduce today's speaker.
Thank you, Lindsay. We're delighted to welcome gastroenterologist Dr. Shirley Paski. Dr. Paski is the Director of Small Bowel Diseases and Nutrition at Cedars-Sinai Medical Center in Los Angeles, California. She's part of the multidisciplinary NET team at Cedars-Sinai and works closely with many of the doctors at Cedars, such as oncologist Dr. Andrew Hendafar and surgeon Dr. Alexandra Ganji, who you are already familiar with as they've been speakers at our meetings and annual conferences. She often sees NET patients who have had bowel surgery and are already on monthly sandostatin or lanreotide shots, who are still struggling with chronic diarrhea. She looks at the bigger picture of all the different causes of chronic diarrhea to better address how to treat the symptoms. Dr. Paski is now going to share her insights with us. Welcome and thank you, Dr. Paski.
Hi, everyone. My name is Shirley Paski. I'm a gastroenterologist at Cedars-Sinai Medical Center, and I'd like to thank the organizers for giving me the privilege of giving the following presentation on management of diarrhea in neuroendocrine tumors. So to start out, I'd like to just bring everyone into the definition of what is chronic diarrhea. By definition, we're talking about diarrhea that lasts for greater than 4 weeks, consists of 3 or more stools a day, or has a total weight of greater than 200 grams per day, which is about half a pound, and is also decreased in consistency. You'll see on the right the Bristol stool chart, and this is a way of characterizing stool based on the consistency in a scoring system that allows for common language amongst patients and their providers. So as you can see here, constipation would be defined by Bristol stool type 1, whereas type 4 is right in the middle, like a sausage or a snake, smooth and soft. So diarrheal stools are considered type 6 and type 7 on the Bristol scale. So what causes chronic diarrhea in the setting of neuroendocrine tumors? The one that can be really blamed directly on the neuroendocrine tumor itself is neuroendocrine tumor hormonal hypersecretion. And we'll talk about that and the mechanism of that momentarily. It can also be due to pancreatic exocrine insufficiency, short bowel syndrome, bile acid malabsorption, medications, including somatostatin analogs and antineoplastic agents. As well, we can't forget about all the other causes of chronic diarrhea, of which there are too many to really list. So during the evaluation of diarrhea, your provider will ask you many questions because it's really important that we get a good idea of the diarrhea description and the associated symptoms. So we'll be asking questions about the consistency, the frequency, whether or not you're having other symptoms of sweating or flushing or fast beating heart, dizziness, pain, change in bowel habits, etc. During your interview. We'll also ask you questions about your neuroendocrine tumor history, as well as your medical and surgical history, particularly to that pertaining to the GI tract, as well as your family history. And the family history becomes important in dealing with all the other causes of diarrhea as well. We'll ask a lot of questions about medications, and that includes prescription medications, as well as supplements, herbals, and complementary therapies, as these can also have a significant impact on bowel habits. Following gathering of the history and medications, we'll probably ask to have some labs drawn, and you'll see some of the labs that we include here. We may include additional labs depending on your nutritional status, or if there are other features of the history that would suggest that we need to check into other things. There are also specific neuroendocrine hormone levels that we may want to check in blood work, as well as a 24-hour urine 5-HIAA, which is a marker of serotonin production. We'll ask for stool studies because that will help to characterize the type of diarrhea and really help to identify the etiology and direct us in the correct direction for management of your symptoms. And then to tie everything together in the background, we'll also want to have a good idea of your GI anatomy and the motility of your GI tract. So if you have any operative reports, imaging studies, reports, as well as the CD images, endoscopic reports, and pathology reports, those are all really helpful for us to get a full picture of the diarrhea and to help better manage it. Since I'm a gastroenterologist, I thought I'd bring some pictures of what I see when I am looking for a small bowel neuroendocrine tumor. GI neuroendocrine tumors are often the hormonal secreting tumors, And in particular, the small bowel neuroendocrine tumors can in fact metastasize fairly easily and may also be hormone secreting as well. You'll see here in the video, this is a capsule study, and you see the lesion in the lower left corner, and then another one in the lower right corner, and then you see another one at the bottom as well. And these are what I am looking for when I'm reading a capsule study. In the images on the right, those are the images that I saw when I did something called a double balloon enteroscopy, or a deep enteroscopy, where we have scopes that are capable of going deep into the small intestine. Through this method, I am able to confirm the diagnosis of a neuroendocrine tumor with biopsy specimens, and I'm also able to mark the location of the tumor with a little bit of tattoo ink directly into the small bowel. Typically, we follow up the findings that I see on the endoscopic examination with imaging studies. And you'll see in the imaging study on the left-hand side, this is a 68 dotatate PET scan that is exquisitely good at looking at neuroendocrine tumors. As you can see here, there are all of the small lesions that look like the little studded dots in the lower left-hand corner. You'll also see the larger areas where there's the contrast pickup, and those are actually normal areas of the liver, the spleen, the kidneys, and deep in the bottom of the screen is the urinary bladder. To the right, you actually see the specimen that was taken out of the patient that you saw in the video, as well as the other images that I took during the endoscopic examination. You see where the tattoo is, marking the most proximal end of the lesions, and the surgeon was able to use this as the landmark to more accurately remove the necessary amount of bowel without taking too much, but without taking too little either. The technique of being able to do the endoscopic evaluation, combine it with the marking, and then having the follow-up on the surgical specimen makes for easier and less complicated surgeries. When individuals are experiencing diarrhea, there are some general management strategies for diarrhea, and these are strategies that one can take almost regardless of the cause because they apply to most people. One of the strategies is spreading out smaller meals over the course of the day. This reduces the amount of food that's entering the GI tract and puts a little bit less pressure on the GI tract to process that type of food, and it can lead to less amounts of diarrhea. Another strategy is to separate liquids from solids. I like to liken this as separating things by about 20 minutes. So you eat your food and then you sip fluids throughout the day in between meals, as opposed to eating a meal and then flushing it all the way through with the fluids that you consume afterwards. By sipping fluids, we generally want to avoid some fluids that are associated with diarrhea, although I do find that each individual will have certain fluids that are easily tolerated and other fluids that will not be tolerated. And so this is an individual preference based on your symptoms. And these are not absolute rules at all. One thing we know is that every body is a little bit different, and we have to customize management to each individual. We also use a lot of oral rehydration solutions to help make up for the losses that people experience. Some people will find benefit from using soluble fiber supplements like Citracel, in particular the capsules. And what these do is these help to add some bulk to the stool. So if you notice, if you were to mix something like Metamucil or Citracel in water, it actually forms like a gel where you can actually stick a spoon straight up if you have a thick enough slurry. And what you want to do with the capsules is to be able to drink the fluids and have it absorb some of the extra fluid that's contained in the stool and thicken it up to reduce the diarrhea. Now, I say that with a little bit of a caveat because not everyone responds well to fiber supplements. And so again, it's an individual response, and you can see if it's a good therapy for you. When it comes to antidiarrheals, the antidiarrheals that we use most commonly are listed here. We have one of the over-the-counter medications, Imodium, listed at the top, as well as prescription medications listed below, including Lomotil, ondansetron, also known as Zofran, codeine, which is an opioid, and tincture of opium, which is a liquid form of an opioid that some people require for management of their diarrheal symptoms. Generally speaking, I recommend for using antidiarrheals that they're optimally taken about 20 minutes before meals. And if you are having difficulties with nocturnal bowel movements or bowels waking you up from your sleep, then you can also take the antidiarrheals at bedtime. One of the other tips I tell patients is to crust medications to help improve absorption. Now we'll move on to different diarrheal syndromes that we see in the settings of neuroendocrine tumors. The first is Carcinoid Syndrome, which is actually not the most common diarrhea that we see in carcinoid or neuroendocrine tumors, but has the classic features that we all hear about when we train, and also if you were to do a Dr. Google search. So the symptoms of carcinoid syndrome are classically diarrhea, which is watery and typically after meals, hot flushes, wheezing and bronchospasm, and in some cases, even heart failure. The mechanism by which we get the features of carcinoid syndrome is due to the neuroendocrine tumor. And the neuroendocrine tumor actually results in increased stimulation of the neuroendocrine cells to secrete different amines and other substances. The serotonin that is secreted by the neuroendocrine cells will result in a direct impact on increasing GI motility and peristalsis, or the contractions that propel food and fluids through the GI tract. This is also associated with an increased secretion of water, as well as the salts, sodium, chloride, and potassium into the intestine. And with the increase in GI motility, propulsion of food and fluids from proximal to distal in the intestine, as well as the increased presence of water and salt in the intestine, the result is diarrhea. But neuroendocrine tumors can have diarrhea result from multiple mechanisms in the setting of carcinoid syndrome. There is also an increase in neuroendocrine cell secretion of something called catecholamines, or norepinephrine, and this further augments serotonin secretion and the downstream effects of serotonin, which lead to diarrhea. The neuroendocrine cells also secrete vasodilators called prostaglandins, which have a similar effect of serotonin on increasing GI motility and peristalsis, as well as secretions. And finally, there is also direct secretion of a substance called motilin. And this peptide results in the initiation and stimulation of the interdigestive migrating motor complexes. And these are sort of the housekeeping complexes that help to propel any food that's remaining in the stomach or fibrous substances that haven't been fully degraded all the way through and into the small bowel, and then downstream throughout the entire GI tract. So with the combination of all of these things, you can sure see how people would end up with diarrhea. The hot flushes, wheezing, and bronchospasm, as well as heart failure, are caused by the other mediators, such as histamine, that are also secreted by the neuroendocrine tumors. But we are focusing on diarrhea during this presentation, so I won't go into more detail on those. When it comes to management of diarrhea in the setting of carcinoid syndrome, we have the basic cornerstone of therapy in the form of somatostatin analogs. What these do is reduce the hormone levels or tumor load, and as a result of these measures, reduce the Carcinoid Syndrome symptoms. So there is the octreotide Benfezia pen, which is a sub-Q injection pen that can be given 3 times per day. There is also a long-acting octreotide depot, also called the Sandostatin LAR, which is dosed once a month, and that's an intramuscular derived depot. There's also another newer one called lanreotide, or a somatulin depot, and that's a subcutaneous injection that's given every 4 weeks. The way one would dose these different options for somatostatin analogs is sometimes driven by your insurance options, but some individuals may find it easier to have an injection that they can adjust the dose on 3 times a day in a day-to-day dose, or other people who have more steady requirements may find a benefit from just having the injection once a month. And certainly sometimes it's easier not to have to do an injection 3 times a day. One can expect to experience improvement in diarrhea as well as flushing, and this is associated with a reduction in serotonin production. And it's seen on laboratory testing when we also see a reduction in the 5-HIA in the urine. Overall, the somatostatin analogs are well tolerated. We do have to do some monitoring for injection site irritation. There are some individuals who will actually experience a paradoxical increase in diarrhea. As well, we have to monitor for gallstones, hyperglycemia, as well as a little bit of slowing of the heart rate, also called bradycardia. Other agents that can be used to manage diarrhea due to carcinoid syndrome are tryptophan hydroxylase inhibitors, of which we have Zermelo. And this is a tablet, is a small molecule that's taken 3 times a day. And it's typically used to augment the use of a somatostatin analog, or people who have not had sufficient relief in their symptoms with a somatostatin analog. It can result in an additional 20% reduction in diarrhea, reduction in the 5-HIAA levels, as well as improvement in nutritional markers. Generally speaking, it is well tolerated, but there is a warning on it that in some individuals there is the rare complication of constipation, bowel obstruction, or even bowel perforation. So constipation is a symptom that does have to be taken seriously with this medication. Finally, there is also interferon alpha. However, due to its side effect profile, which includes flu-like symptoms and depression, as well as others, we limit it to use for salvage therapy, not very oftenly used. Another etiology of diarrhea is pancreatic exocrine insufficiency, and this may be due to any upper GI surgery or injury to the organs that you see here. Symptoms of pancreatic exocrine insufficiency include diarrhea, gas and bloating, abdominal distension, foul smelling or oily or foamy stool representing malabsorption, malnutrition, and weight loss. You can see here what happens when we have pancreatic stimulation. So chyme from the stomach results in an increase in secretin production in the duodenum. The secretin production then stimulates the pancreas to produce bicarbonate as well as secrete digestive enzymes. These digestive enzymes, in the form of proteases, which digest protein, lipase, which digests fat, and amylase, which digest starch, then get secreted into the small intestine. If there is any abnormalities in the anatomy that you see here, for example, a loss of the stomach, loss of the duodenum, loss of the pancreas through surgical measures, or through damage to the duodenum to reduce the ability for it to produce secretin, we can see a reduction in pancreatic enzyme secretion into the small bowel. When there is pancreatic exocrine insufficiency, this is typically detected on stool studies to confirm the diagnosis. And treatment is with pancreatic enzyme replacement therapy, otherwise known as PERT, with meals and snacks. For pancreatic exocrine insufficiency related to neuroendocrine tumors, the enzymes that have most been studied are creon, which comes as a delayed release capsule, and Viocase, which comes as an oral tablet that is non-enteric coated and needs to be taken with an acid blocking agent known as a proton pump inhibitor. These can be something like omeprazole or pantoprazole. It should be noted that Viocase does contain lactose, and so people who are lactose intolerant may have difficulty with it. It's also important to note that the amount of pancreatic enzymes required are going to be dependent on the amount of remaining pancreatic exocrine function, as well as the individual's weight and their dietary contents. Underdosing is quite common, as the pills and capsules come in doses from everyone that is treated as a young child with pancreatic insufficiency due to something like cystic fibrosis to a full-grown adult whose requirements due to the amount of food that they need to digest is going to be markedly different. So it's important to make sure that you are receiving the correct dose. Food and enzymes and pancreatic enzymes need to be together at an alkaline pH in order to optimize their ability to digest food. And that means that the pancreatic enzymes need to be taken with the first bite of food. What this demonstrates here is that as the food moves from the stomach to the small intestine, the pancreatic enzymes are going to be released into their active form and will be able to act in the small intestine to digest the food that they are consumed with. And then this food can be uptaken into the small bowel and into the body. However, if you take the enzymes about 30 minutes or even an hour before your meals, and they're already in the small intestine, they're long gone before the food has even arrived. Conversely, if you eat all your food and you have had the food actually exit your stomach and already go into the small intestine and wait until after your meal to take your enzymes, again, you have a lot of your food that's not coming into contact with the enzymes and is not getting digested. So don't forget to take the enzymes with the first bite of food. Short bowel syndrome is another etiology of diarrhea that typically stems from an extensive bowel resection. And this is usually in the setting of multifocal neuroendocrine tumors of the mid-gut or small intestine. Or it can be due to complications related to prior surgeries or other illnesses. You can see here the different types of short bowel syndrome that one can have. Figure A on the left shows somebody who has had a very large part of their small intestine removed. Figure B shows somebody that has had a large part of their small intestine as well as a significant amount of their colon removed. Both A and B are the typical patterns of short bowel syndrome that we would see with neuroendocrine tumors when we do see short bowel syndrome caused by small bowel resections. In rare instances, we would see somebody who has had their entire colon removed, usually for another etiology, as well as an extended amount of small bowel removed, leaving them with a stoma or an ostomy, where the stool contents come out on the surface of the abdomen into a bag, and this can cause short bowel syndrome as well. The fluid and nutritional requirements in each of these settings is a little bit different, but one thing that's common amongst people with short bowel syndrome is that they all will require long-term management, and this is usually with a surgeon and a gastroenterologist. Long-term management of short bowel syndrome involves dietary and lifestyle measures to optimize utilization of digestion and absorption in the GI tract. I always remind my patients that digestion starts in the mouth and to remember to chew, 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 chew very well before swallowing. Take advantage of the time that you can use the GI tract. Since food travels through quickly, it's important to give your bowels multiple opportunities to digest and absorb food. And this is typically in the form of 3 meals and 3 snacks daily. Oral rehydration solutions are also common, especially if a significant amount of the colon has been removed. And these may come in the form of prepackaged oral rehydration solutions in the salts like Trioral, or flavored combinations like Pedialyte or Drip Drop. Or, as you can see in the second from the right, there is a homemade formulation. On its own, the taste is like seawater and not very palatable. So what I usually recommend to patients is to add some of these Mio sweet drops, and they come in a variety of different flavors, just to offset some of the salty taste. But again, this is the most economical of all of the options. In some patients with short bowel syndrome, we usually have to use antidiarrheals and vitamin and mineral supplements. And in some patients, we also have to use forms of nutrition support. And this may include something like a feeding tube that you see in the upper right corner. Sometimes we require the use of IV nutrition or hydration. And sometimes we need to use additional growth factors like teduglutide to increase the surface area of the intestine, or another hormonal regulation called exenatide to slow down the motility of the GI tract. This is all usually done also in conjunction with a GI dietitian. With bile salt malabsorption, moving on, we can see this typically in people who have had short segment distal ileal resections or resection of the ileocecal valve and a short segment of the small bowel and a short segment of the colon. It can also occur as a result of excess bile secretions or just mal-timed bile secretions because of lack of the usual anatomy and checkpoints in gallbladder, with either a gallbladder removal or attachment of the gallbladder to the small intestine, which is called a choledochojejunostomy, as is present in many patients with a Whipple. Symptoms of bile salt and bile acid malabsorption are watery diarrhea. The way this mechanism works is that the last part of the small intestine is very important for reabsorbing your bile salts. In fact, 95% of your bile salts are reabsorbed in the last part of the small intestine, so they never reach the colon. When you're missing the last part of the small intestine, then this results in excess secretion of bile salts into the colon, or I should say excess transit of bile salts into the colon. The bile salts cause a direct irritation to the colon and result in an increase in water transport into the colon and an increase in diarrhea. Fortunately, bile acid malabsorption is easily managed with the use of bile acid binders. There are a few different forms of this. Cholestyramine, or Questran, is a powder that can be mixed with fluid. And then Welchol, or Cholestipol, are capsules that can be used to help sequester the bile salts. Once the bile acid binders bind to the bile salts, they carry them all the way through the colon. And because they're bound to the bile salts can no longer have an impact on the water secretion into the colon. Now, it's important to realize that the bile salt binders can also bind to your medications. So you need to take them either 1 hour before you take your other medications or 4 hours after you take your other medications. It's also important to note that sometimes we don't know exactly how long the bowel is that was removed in the ileum. And so for individuals with short bowel syndrome, even though they still have a colon present, there is a chance that the bile salt binders will actually bind too much of the bile salts that are available, because these patients are actually bile salt deficient, and then you get a worsening of fat malabsorption. So again, it's important to pay attention to the response of diarrhea to your medications. And if it's not working, then speak to the prescriber. Finally, other medications. There are so many medications that are involved in chronic diarrhea. Some of these may be the systemic chemotherapy or combination therapies that are used to treat neuroendocrine tumors that can cause diarrhea in some individuals. Proton pump inhibitors can cause diarrhea in some individuals as well, and this diarrhea can be variable based on the type of PPI. And so if one causes diarrhea, then sometimes it's reasonable just to try switching to an alternative one, and the diarrhea may be significantly less. There are also magnesium and potassium supplements, NSAIDs, antibiotics, sorbitol-containing medications, metformin, and antidepressants that can all be common medications associated with diarrhea. So review these medications and their indications with your provider if diarrhea continues to be an ongoing issue for you. And this is an example of just some of the other causes of chronic diarrhea in people. And it's important to realize, and the reason I put this slide up, that while neuroendocrine tumors and diarrhea are often directly related, there are also many, many, many other causes of diarrhea. And if you haven't received an adequate response from the therapy that you have been on for the neuroendocrine related diarrhea, we should also be considering other etiologies. I have one slide as well, just on constipation and partial obstructive symptoms that may follow surgical resections. So in this setting, it is unfortunate that some individuals will go on to form adhesions, strictures, which is fibrous tissue, at particularly the connections or anastomoses in the bowel, or develop dysmotility related to damage of the vagus nerve, and the housekeeping mechanisms that help with GI motility. Often the partial obstruction symptoms manifest as constipation and bloating until there is a significant or a sufficient pressure for the backup to then pass through that partially obstructed area. And then this leads to diarrhea, often significant and multiple episodes. Small intestinal bacterial overgrowth can also occur in these partial obstructed areas, and this can be tested for with breath testing. The general management in these cases is to try to keep things flowing forward through the GI tract. In the case of structural problems, a mechanically altered diet may be required, smaller portions, as well as the gentle use of laxatives, and sometimes surgical or endoscopic management is needed. In the case of intestinal dysmotility, additional pro-motility agents based on the area that's affected may also be required. So, in summary, evaluation of diarrhea in patients with neuroendocrine tumors requires a careful and thoughtful evaluation. Management of diarrhea often requires a combination of diet and lifestyle modification, medications, and sometimes surgical management. And finally, if you aren't seeing improvement in your symptoms, consider evaluation for other non-neuroendocrine tumor causes of chronic diarrhea. Thank you for your attention, and I'm happy to answer any questions.
Hi, Dr. Paski. Thank you for the very thorough review of diarrhea and constipation and all the different causes, the treatment and management. Just wanted to thank you for that really helpful presentation. As you know, it's a common issue, and we've already gotten about 25 questions in, and I really appreciate you giving your time to answer some of these. So let's start with the first question. I guess it's a really common, this is a common question that's going to happen when the patients come in. So you've already given a really good explanation, but really, when it comes to a patient, they really want to know what can be done is there a way to reduce the number of bowel movements? And, if someone's coming in with 6 to 8, how would you go about thinking about that and, and helping them reduce it?
Right. That's a good question. So again, I probably need a little bit more information to sort of answer this question completely, as what works for one person may be a little bit different from what works for another person. If somebody is completely on, no antidiarrheals whatsoever, then this may be somebody that just benefits from a little bit of, Imodium or Lomotil, just to sort of help slow down transit a little bit and buy it a little bit more time, to try to consolidate some of the stools. Also, if there are trigger issues, or if people are waking up at night, then you may want to just adjust the dose of your antidiarrheals and the timing that you take them. Or if you have specific medications, that are dosed frequently that also add to the diarrhea, you may want to sort of adjust the timing that you're taking these. So, there's quite a few different options here, and a little bit more information on the patient's anatomy might be helpful too.
Right. Oh, and as we said in the very beginning of the program, of course, we understand this isn't a substitute for talking to doctors, and of course, we always encourage patients to talk to their providers, and everything is case specific. So, I think that's a really helpful thing, right? You mentioned there's a lot of treatment options, and in that, you need more information and then figure out which one of those treatments might work. I think, let's see. And going into that area of the workup, how can you tell if the diarrhea is from high serotonin and carcinoid syndrome versus SSA? What test should I anticipate or ask for? You named a wide variety of tests.
Yes.
So what would a patient anticipate? All of them? Some of them? What should they expect?
Yeah, exactly. No, that's a good question. I think this is when the timing, and the lab tests are going to be really important. And so, you've got the baseline measurements of the 5-HIAA, and then the other secretory hormones, if those were an issue and were elevated as well. And also the imaging studies that were done too. And so you can get an idea if those have been increasing or if they've been steady. Or if they were included with, like, if the flushing and everything is also included along with the diarrhea, then that would suggest that it's going a little bit more towards the high serotonin carcinoid syndrome as the etiology of the diarrhea. Whereas if, you had those symptoms, some of the flushing got a little bit better, but then you're noticing, like, potentially like fatty or oily stools, then that may suggest that perhaps the octreotide or, the diarrhea started after or got worse after you started the octreotide. That would sort of go more towards the SSA.
Yeah, and
so just checking stool studies, and then also checking the 5-HIAA in the urine, the 24-hour collection will be helpful there.
Looking at the whole picture again, the other symptoms, and then starting with a couple of studies, 5-HIAA. And I know you already talked quite a bit about serotonin and how that leads to diarrhea. I guess understanding, is it both from the food and then naturally what's released in the body, that effect? And if you could just kind of review it again very briefly.
Yeah. So the serotonin, basically what it does is it has a direct impact on the GI tract to increase motility. So basically it increases the contractions of the GI tract to sort of propel food and fluids further along in the intestinal system. The second thing it does is it encourages secretion of electrolytes, which water follows, into the GI tract. So that's how you get things both moving through quickly and also more watery too. And with all of that, when you see things moving from one place to the next very quickly, that leads to diarrhea. The undigested food in the colon or in areas of the small bowel where there may be dysmotility from previous surgery. A lot of the gas will end up being as a result of sort of maldigested or undigested food contents, from which the bacteria then have their opportunity to digest and produce their own gas and everything. Because once the food reaches the colon, it can't really be absorbed very well. For the most part, there's some things you can absorb from the colon, but the bulk of food that ends up there isn't digested. If it's not digested significantly and it hasn't been absorbed by then it will lead to the gas and bloating. Same with lactose intolerance too.
Okay. And is that both from what's naturally occurring and the food, as you're kind of saying?
Right. Oh, yes. So, so it's a little bit of a different situation when the serotonin is coming from food. You shouldn't see as much of a significant effect, if anything, in that setting, just because it's all been broken down in the digestive process. But also just the way it's been metabolized. Like part of the reason why the liver ends up with the hormonal release and the metastasis from the liver end up with the serotonin release. It's just that it doesn't have a chance to be metabolized at that point, which sort of leads to these other GI symptoms.
Yeah, thanks for that. That's really helpful, very thorough. And along the lines of workup, what blood work would you recommend to check for that malabsorption of the vitamins and nutrients?
Right. So, you know, there may be some specific things like just from a history and a physical exam and knowing the anatomy, we'll kind of have an idea of what things that an individual is at risk for becoming deficient in. And also if you have a history of weight loss, that will certainly gear towards that as well. For basic screening labs for an individual who's had a GI resection or where I'm concerned, you know, because they've lost significant weight, I usually check 4 different things. So I check a vitamin D because that's a fat-soluble vitamin and requires intact biliary secretions as well as sort of the ability to combine those things with enough dietary fat in order to be sufficiently absorbed. And then there's also a vitamin B12, which I check in my screening. And that's just because it's very complex and requires actually an intact stomach, pancreas, proximal small intestine, and terminal ileum to be absorbed adequately. And so it's something else that people can become deficient in fairly easily. I check folate, folic acid level as well, and that's as a B vitamin, particularly in people with a lot of diarrhea, and certainly as they're more gluten-free foods that aren't fortified with folate. It used to be the most common deficiency in North America, so it's a little bit more of a traditional B vitamin to check, and then also checking iron indices as well. Because a lot of people who have had issues with the GI tract will have difficulty with iron absorption, and that's absorbed predominantly in the very first part of the small intestine, in the duodenum, right after it empties the stomach. And so, if you've got any injury to that area of the small intestine, you're at risk. As well, any signs of GI bleeding, especially if there's a midgut issue or other GI issues, you know, people are prone to those. So usually I check those 4 as a start. I'll often check a zinc too in people who have very significant diarrhea, just because that's often lost along with high volumes of stool. And then if all of those are normal, usually that's a pretty decent screen. If there's anything that's abnormal, or if I'm concerned about other things, then I'll do sort of like a much broader panel. There's 13 essential vitamins and then sort of 5 essential minerals. And you can check those things too.
Yeah, that's really helpful. I'm glad that you mentioned checking those vitamins. I know that question has come up quite a bit in our discussions in our support groups as well. And you mentioned about the high iron. So this question came up. Someone has a hemochromatosis, so high ferritin and iron. Is that what might be causing chronic constipation instead of diarrhea? And thank you for that Bristol stool chart. I think that was really helpful. So she could rate it 1 to 2 and 5 to 6 on that Bristol stool chart.
Yeah, you know what? It shouldn't be. Not the hemochromatosis on its own. Sometimes, with the hemochromatosis, you can get deposition of iron in a few different places. So, but it's usually like the liver. Of course, you have to worry about other endocrine glands like the pancreas and everything as well, and pancreatic insufficiency, and that's sort of what they call, diabetes and everything related to that. And it, and other organs as well. But usually it doesn't affect GI motility. So I'd be thinking something else for that individual.
Okay. So along the lines of constipation, there were a couple questions about that. So what could be done to address persistent post-surgery constipation that might be caused from adhesions and gastroparesis?
Yeah, that's a good question. Very common in my world. So it's going to depend on a couple things. One, the timing of surgery, and then also just getting an idea of, what sort of anatomy we're dealing with here. There's some people who have had multiple surgical procedures and their abdomen is, really frozen down. And at the same time, because they've had so many surgeries and there's so many adhesions and scar tissue, people really aren't going to be wanting to do another surgical procedure outside of an absolute emergency. But people still remain pretty symptomatic. So, and then this is in comparison to someone who may have had surgery, just recently and, is just dealing with a little bit of post-operative, kind of what we call an ileus or sort of a slow bowel function, where previously dilated bowel proximal to where the neuroendocrine tumor was resected is still just trying to kind of restore its usual compliance and everything. And that type of stuff is, expected to get better over several weeks, several months, and you can expect improvement there. So there's some general measures for managing this. Typically, we start out with trying to go for more like a mechanically altered diet. And that starts with chewing well. And sometimes the utilization of, a blender or purees and things that are just going to mechanically go through those narrowed segments or the sort of kinked areas where the adhesions, what happens is they're sort of, one's pulling the bowel this way, the other's pulling the bowel that way. So the area in the middle where the food has to go through is going to be a little bit difficult. And so, having the mechanically altered diet and more of a liquid consistency going through can be helpful, as well as sometimes just addition of just a little bit of Miralax and kind of measuring the food out and spreading it out over the course of the day. So you're never overwhelming the system with a large amount. Some other things that I've done, especially for people who aren't surgical candidates, is we have referred them to like a clear passage or similar type abdominal massage, where experienced massage therapists can kind of work on some of those adhesions and just sort of soften them up or identify them. And so the patient can identify to the areas that they can literally need just a little bit of mechanical push to get through. I should just mention too, the one thing I try not to do is completely restrict fiber from the diet of people who have adhesions, because there's some soluble fibers that are still going to be tolerated just fine. And those are good for overall health as well. And so it may just need to be provided as fiber in a different form, and something that's, soft and mushy and can go through those areas. Now for gastroparesis, that's a little bit of a trickier one. This is really the world of motility. I do think it's important to actually get a clear diagnosis of gastroparesis. And that's done with the gastro study.
Could you first define that and explain what gastroparesis is?
Gastroparesis is it's slow emptying of the stomach, typically from motility issues. And that may be, after doing surgery, like a Whipple, for example, then, there may be some injury to the vagus nerve, which helps to regulate bowel movement. And so some people will get gastroparesis related to that. And so with the gastroparesis, sometimes people can benefit from medications that augment the motility of the stomach. And then again, we usually recommend sticking to smaller meals. Sometimes they have to be a little bit lower in fat, a little bit more liquid in consistency. Sometimes we have to reduce the, kind of like insoluble fiber as well, just to help the stomach to empty faster. And then, with both of these, one thing to remember too is that even though there's some pain involved with it, it's important to kind of differentiate pain that's responsive to, sometimes it's responsive to narcotic medications, but narcotic medications can worsen both of these conditions. And so sometimes it's more antispasmodics that need to be used instead, or correcting the underlying cause and keeping things flowing through.
Yeah, thank you for that really thorough response. I think that really magnifies the importance of understanding the cause behind the diarrhea instead of just jumping to a treatment, right? Because it could be, like in this case, adhesions or gastroparesis, or you're saying even both.
Okay. Exactly.
Okay, and similarly to that, some people swing back and forth from diarrhea to constipation. So how would you balance that and find that, instead of seesawing back and forth, really find that balance?
Yeah, I find that the people who alternate back and forth often have a little bit more primary constipation. And what happens is they find that the stool sort of builds up, and then they release what I call kind of like the plug per se. And then the whole tidal wave of all the stool that's backed up for the last 5 days or 7 days or more sort of follows once that's released. And so, patients like that I find really benefit from what I call like an anticipatory bowel regimen. So it actually ends up being more primary treatment of constipation to avoid having, a high backup of stool. And by avoiding that, you can kind of avoid having the sort of subsequent diarrhea that follows. Some of the agents like soluble fiber supplements can also be helpful with sort of normalizing things as well in this setting. It is I'll also just say it's important to remember not to alternate between the use of laxatives and antidiarrheals. So when you start to run into that problem where you get constipated, and then you take a bunch of laxatives and you get diarrhea, and then you take a bunch of Imodium, and then you're going back and forth. It's like, no, we just have to stop that pattern and sort of gear towards one or the other.
Yeah, I think how you describe it, right? It's primary constipation, so there's a plug there, and all the loose stools going around it is a nice kind of picture to understand that, and you want to unplug that plug.
Exactly.
Okay, that's helpful. Thanks.
And prevent it from being formed in the first place.
Right, keep it from being formed. So related to that, someone shares that it takes 3 fiber gels a day for 3 days before this person has a diarrhea bowel movement, a loose bowel movement, and without the laxatives, that person, it might be shooting pellets or not going at all. So is that typical of NETs?
Yeah. So this is actually sounds very similar to kind of like a little bit more of that, where it's sort of like an accumulation and then maybe even overflow around the area. So I think this is somebody who would probably benefit. Well, we have to assess their anatomy and all that stuff too, but would probably benefit from something like just a very gentle laxative to kind of prevent and keep the flow of stool moving all the way through. Even something like polyethylene glycol, also known as Miralax, is something that you can kind of the amount in, and something that you can take every day just to sort of keep the pathway moving and to keep the consistency of the stools sort of soft. Be helpful.
Yeah. So continuing on the fiber gels and maybe adding a mild laxative like Miralax. Okay. And just as a reminder, is Miralax a prescription drug, or is that something that you can take over the counter?
That's over the counter. If you're having ongoing problems, you should probably talk to somebody about it. One of the, like either primary care provider or gastroenterologist or the surgeon. They may have some insight too, actually, based on the surgical procedure that they did, what the diarrhea and the change in bowel habits is from.
And you're saying because they know your anatomy, so they would understand that.
Exactly.
Yeah. Okay. So kind of along those lines again, there's someone who asked specifically, do people take both Imodium and Lomotil? Because they seem to work differently. Is it okay to rotate between them? And which of them seems to cause more blockage with use?
Yeah, you know what? You're okay. They both work in a similar sense to sort of slow the transit of things through the GI tract, and that essentially gives more time for fluids to be absorbed. And so, I actually have a lot of patients who take both, and and the reason for that is, well, sometimes people find one works better than the other. For them, and so it's patient driven by that. Sometimes I'll combine them in the sense that when you take Imodium and Lomotil together, they kind of augment each other. So instead of like 1 + 1 = 2, it's almost like 1 + 1 = 3. And so that can sometimes be helpful just to reduce the number of pills that people take by taking advantage of that sort of synergistic effect between the two. So it's okay to rotate from a safety perspective. It's okay to combine. I do say, in my kind of like overall limit, really, you shouldn't take more than 8 of each pill a day. I think once you're going beyond those numbers, well, first of all, that's a huge pill burden. But second, you've kind of maximized the benefit that you're going to get when you at that sort of a dosing range. As far as like which causes more blockages, I have not experienced a difference of one more so than the other. And the issue of blockages really becomes a problem with people who have a lot of scar tissue, a lot of adhesions, and they're always on that borderline. It's very tricky to manage, with the diarrhea, but things to get just a little bit too firm behind that blockage because they actually become symptomatic.
Yeah, so this is really helpful.
Both medications that you have an issue with and need to watch.
Okay, yeah, there were actually a couple questions about Imodium and Lomotil, and it seems that people are really concerned about whether or not they can take it safely. So this is helpful. You're saying yes. Bottom line, yes.
Yeah. Bottom line, yes. Just some people will find that the Lomotil, it ulcers. They're kind of like they get a little bit altered. And so, the Imodium doesn't cross the blood-brain barrier, so you don't get that effect unless you take like really like huge amounts of it. I think that's more of kind of like a addiction issue than anything else at those levels. But it has affected the average consumer, because now if you buy it over the counter, you only get these little blister packs and they'll only give you a maximum of 24. So it's just, for some patients who need to take 8 pills a day, they're going and buying boxes and boxes of this stuff. So that's when actually the prescription can be helpful, because the pharmacist can package it a little bit more effectively.
Oh, that's a really good point. Yeah, so the prescription is helpful, even though you can get it over the counter. Okay. And along those lines of these medications, when is the proper time to take the cholestyramine oral suspension, before or during the meal? And if so, how long before the meal?
Yeah, I always struggle with this one because it sort of affects a little bit of absorption of your meal contents as well. The question is, are they getting the bile salt diarrhea pretty much directly related to meals? That's the question. I actually often have my patients take it if it's just like very simple bile salt kind of diarrhea. Sometimes just reducing the amount of bile salts in the intestine that have just kind of been released, sort of like in that overnight in between meal period, can be helpful. And so actually just taking it before meals or in the morning, kind of like take all your other medications, wait an hour, then take, the cholestyramine, and that can be enough just to, usually people just need a whiff of it once or twice a day to help out with that. I am open to playing with the timing though, because if that isn't effective and people are like, well, but it's always reliably with meals and probably more with fatty meals and stuff too, then they may find that it's just, you know, if they take it with the meal, they get a better effect. We just have to be a little bit more cognizant and maybe binding up a little bit of the contents of the meal too, as far as like nutrients are concerned.
Okay. So some people before the meal, some people with the meal.
Some people after, you know, honestly, it's like whatever works best. You know, you can play with the timing. The only thing you just have to really watch is the timing with medications. Medications, vitamins, supplements, that kind of a thing. So, so watch that. But otherwise, I mean, there is a little bit of almost a little bit of free reign, as much as you can get with cholestyramine. But you can adjust the dose and see what works best for you.
Okay, so watching the medications most important, and then really figuring out what works for each person. Okay. So along those lines, you know, are the bile salt binders, so the Questron, Cholested, and Well prescription medications, and how would we as patients know if these would help for us?
Right. So, you know, as a patient, you know, usually it's like watery diarrhea, and if you have a history of gallbladder removal, you know, Whipple, or resection of the last part of your small bowel or the terminal ileum. Those are sort of the three things that would kind of put you towards that. And then, you know, the other time that I see is I'll actually check, you know, stool studies, and you get a little bit of a secretory type diarrhea with it. And patients who have a secretory diarrhea, you know, they sometimes will benefit from the bile salt binder too, almost like a little bit empirically when we've ruled out things.
Okay. And you're naming, you know, many of the NET patients because they've had, you know, those type of surgery.
I know. So it's one of those things. It's like, okay, well, just, you know, talk and see, because if you've got those conditions, it's like, it can be worth trying, you know?
Okay. And going to a really common medication, right, the SSAs, how do you differentiate between the Sandostatin LAR and the Somatuline? Is one better than the other for certain patients?
Yeah, you know, I have experience with the somatostatin LAR. I've actually never had to prescribe the Somatuline, so I don't have experience with that one. It's newer though, so you know, we'll see as far as where it ends up getting positioned and everything. To be honest, it seems like insurance companies drive a lot of these decisions anyway. Unfortunately, and so it sort of just depends on what your formulary will be, and if you fail one, then it's like, okay, well, maybe try the other one.
Mm-hmm. And that was actually another question
this time.
Okay.
Yeah.
And so regarding the GI symptoms, diarrhea, would changing one to the other make a difference, in your opinion?
It's like one of those things. It's kind of like potentially, you know, I think you just have to be objective. Actually, that's where keeping a little bit of a loose journal, and just keeping track objectively of symptoms and stool pattern and all that stuff. And then you have the medication change, and you just keeping track of your symptoms and everything. So otherwise it gets really hard to remember, oh yeah, with this medication, but I only took it for 2 days and then I got sick and I was on it. You know, it's just easier just to write it down, even if it's just on, like, you know, one of those calendars where with just tally marks and a couple notes, then you can actually go back and look at it and try to make sense of some of those things.
That's a really good point, right? Keeping a symptom journal, a log, is really important. So we know what medications and foods and such are affecting the symptoms.
Exactly.
Okay. So one more question about the somatostatin analogs. How long after the injections, whether lanreotide or sandostatin, will the white colored diarrhea and soft stools last?
Hopefully not that long, you know, because if, you know, you don't want to have biliary sort of kind of like insufficiency. for super long periods of time. So you're hoping just to slow it down, and then as the depot kind of wears on, you should get sort of return of normal color stool again. So definitely mention that one to your healthcare provider.
Mm-hmm. Okay. And as you know, there's been an even newer development with the Bemphisia pen. So what's been your experience so far, and has there been issues getting it approved?
Yes and yes. So I actually just have a couple patients on the pen at this point. And so it's been an issue getting approval. It's a little bit more
could you back
expensive.
up and explain what it is for some people who might not
The
have
pen,
heard?
yeah. So basically, diabetics know all about this. So insulin used to be dosed where you actually had like either pre-filled syringes, or in the old times, they had to draw it up in a little bottle and all of these things. And then it actually got converted over to a pre-filled pen where you actually just need to adjust the dose on a clicker. And these are just automatically pre-filled pens, can be kept at room temperature, and you just literally touch it to your skin, push a button, and then it just automatically doses the medication. So as far as ease of use, it's much easier and easier to store, requires less supplies. You don't need a sharps container every time you give a dose and all of that stuff. So, the experience that I have with patients so far has been positive. But approval can sometimes be an issue. But I think, if you go for your patients, try to help them out. You can. I think for just quality of life purposes, it's a little bit easier.
Yeah, it sounds amazing, right? Just to take one pen, it doesn't have to be refrigerated. You could, like you said, you can just go on and have your life. So you have been able to prescribe it successfully with some of your patients?
Yeah.
Okay, great, thanks. There's several questions about Creon. As you know, Creon's really common. What dose of Creon do you recommend to start with, and how do you adjust it? And then how long would it take to alleviate symptoms?
Yeah. So, Creon is adjusted based on weight, actually. And so you can go to the Creon website and actually enter in your patient's weight. And then it will tell you how much Creon they need, how much lipase units they need in a day. And so I use that as sort of a starting guide. I do recognize, depending on how much pancreas was removed and how much pancreatic exocrine function is left, it will be variable. So some people will not require quite as much of the enzyme. And so to adjust the dose, we usually adjust it, kind of like ballparking how much, in particular fat and protein in the size of the meal. So if it's a usual size meal, then it's going to be, sort of your standard dose. I try to adjust the dose of the pills that I give. So it's like 2 or 3 for a meal, and then 1 or 2 for a snack, just based on the dose that I can get for them of how much is in each capsule. And so that way you just carry 1 dose around. You don't need, and then adjust the number that you take. And so it's based on that. If it's just something that's a very simple, carbohydrate type of meal, then, sometimes people don't require as much. They've got enough of the sort of salivary lipase and pancreatic function. It's pretty easy to digest and absorb. As far as the symptoms, the Creon only works on the food you take with it. So you should literally notice it on the effect of that meal that you take with the enzymes. So it doesn't have a lasting effect. It doesn't need a buildup or anything like that. It's literally like the dosage with the meal that they're consumed with. And so it's a meal by meal effect.
Okay. So how long would it take to see that effect?
Like when you start taking them? Literally, okay. Like for pancreatic insufficiency, it's pretty quick. Right. It may take a little while to sort of figure out dosing and things like that. But, as far as the number of capsules you take and everything, but people, experience significant improvement like I would say within the week. That's what I tell people.
Yeah. So you mentioned it might take a while to figure out the dosing, and that seems to come up a lot in the patient support groups and the discussion. So how do we go about figuring out dosing?
Yeah, so that's where literally go to the website and punch in your weight, and then you'll know how much you're supposed to take. And it's split up over the day, of course, over the day with all the meals and everything. And I think the thing to be just to keep in mind, I think most people end up getting underdosed intuitively because we use digestive enzymes. Traditionally, it was developed for the kids with cystic fibrosis, and so you're giving it literally like to toddlers. And as I say, it works on the food you eat, and a toddler eats a lot less than a full adult. So it's but they have to make pills that are enough for those little tiny toddlers and everything too. So
yeah, that's a good point. And most NET patients aren't the size of toddlers.
Exactly.
Got it. Along those lines of taking Creon in general, when would you recommend taking it? After what type of surgery, or maybe what types of symptoms, and when would you start it?
Yeah. Well, some people you just know, they had, maybe some chronic issues with their pancreas beforehand from other things, and then they had a Whipple, and they're diabetic already. So you knew that that their pancreas didn't have a lot of reserve to begin with, and then they had surgery. And so, literally, you just know. So it's just, I would just, honestly, I would just start them at that point. But if it's a little bit less clear, then you can actually check the stool sample for pancreatic elastase. So that's an enzyme that's secreted by the pancreas and sort of reflects the pancreatic exocrine, or the digestive enzyme kind of function. And the reason we check the pancreatic elastase in the stool is that it's not broken down by your normal mechanisms and everything. And so it appears in the stool sort of as it is. And so we can use that as a measure of, if it's low in the stool, that means the pancreas isn't secreting much of the digestive enzymes. And, that would be someone who would benefit from the enzyme replacement.
Okay. So, I mean, you're saying you would know from those symptoms, and if you had to, you could check this pancreas elastase. Okay,
Exactly.
got it.
Exactly. Like if it's a question, because I know, a lot of times they don't start everyone who's had a Whipple on pancreatic enzymes. If somebody who has gas and bloating after Whipple, I check that pancreatic elastase, literally like the first appointment. And then we start enzymes if appropriate.
So you mentioned people who have Whipple, and that makes sense that they would need a pancreatic enzymes. What about people who have distal pancreatectomy? So the other half, not the head, but the other half, would they need pancreatic enzymes?
Again, it just sort of depends how much they took, and how much reserve they have. So just check stool sample. I know everyone loves to give stool samples, right? So
our favorite thing.
I try to consolidate everything into one collection, so you don't have to do too many of those.
Great, thanks. And so, I mean, kind of moving over to food, what are the worst trigger foods? I know you kind of touched on this, but what are the worst trigger foods that cause diarrhea?
Yeah. It's going to be a little bit different for everyone, for sure. I think every GI patient has their one or two foods that they just stay away from because they know that it's going to be a problem. But traditionally we say, very sort of high fat, large meals are going to be sort of people's biggest offender. And so, but at the same time, especially for lighter people, fat can be a good source of calories too. So I can't think of anyone that I've put on a low fat diet in a really long time, actually. Sometimes it's a matter of sort of adjusting the enzyme provision and focusing on healthy fats and stuff like that. But being aware that if you go and eat, a barbecue and have a milkshake on top of that, that you're probably going to have diarrhea. So the high fat foods are ones that typically cause problems, and may require a little bit of adjustment in the way that you consume them, as well as the way that the enzymes are used, in order to be able to tolerate. And then some of the other things that are sometimes a little bit, responsible for symptoms are if people have had a significant amount of bowel removed. Sometimes they'll have problems with things like lactose intolerance for a little while, or if there's disease of the small intestine, and need to use sort of more of like dairy alternatives or naturally low lactose dairy type of foods. And then some of the other kind of difficult to digest sugars are the other things that can be associated with diarrhea, like with a lot of the diet type products that have the sort of sugar alcohols, like sorbitol, or mannitol, that kind of add some of these sort of sweet type things, and the concentrated sweets can be difficult for people to tolerate as well. It's just because they pass changed, and then because they're difficult to digest, then the bacteria in the colon get their opportunity to digest, and then you get an influx of water and diarrhea.
I see. You cut out for a second. So you said they pass through unchanged?
Correct. Yeah.
Okay. So really you're saying don't go to town and like eat all the hamburgers, milkshakes, avoid the artificial sweeteners, and possibly avoid lactose.
Yeah. It depends. And it all ends up, it's being very dose dependent too. So you may be able to tolerate these things just in smaller portion sizes. And so, we really try not to absolutely restrict people, just because there's so many limitations that people have as it is. But we try to, work with a registered dietitian to really help identify those trigger foods, and then kind of work within your tastes and preferences and nutritional needs to optimize sort of symptom balance, but also making sure that you get all the nutrition you need as well.
That's really helpful. We like the idea of not having too many restrictions because there's already so many things to worry about. Yeah. So kind of related to this whole area, could you suggest some remedies at home to cope, and also suggest some diarrhea preventative diet options?
Yeah. So, this is somebody it would be really helpful to see in a clinic visit, actually. I'm assuming that it's like, just remedies at home to cope with diarrhea. I think, definitely make sure just from the neuroendocrine tumor that therapy has been optimized. And then, if there's been significant bowel resection, there is sort of period of intestinal adaptation that we use. And, with a lot of these things, you learn on the way. And so as far as like strategies to learn and identify what works, what doesn't work, things do get better over time, but it may require a little bit of a change in diet and lifestyle and all of that stuff too. At home, one of the things for diarrhea, if it's really triggered by, a lot of the fluids, we use a lot of like oral rehydration solutions, and just try to sort of sip those in between meals as a way of sort of just maintaining hydration in between meals. And, you can get some of the recipes for these, but it's not just as simple as buying Gatorade. It's like, for example, using Gatorade G2 with a half teaspoon of salt added. And the oral rehydration solutions, they really help to enhance the absorption of fluid. They turn on water channels that actually enhance the absorption of water in the intestine. And so sipping those in between meals, and sort of separating them from meals by about 20 minutes to allow your food to digest first and absorb first, and then kind of sipping these throughout the day can be helpful, just to reduce the amount of diarrhea that you're having. That's kind of like general sort of basic advice. Also taking the antidiarrheals about 30 minutes before you eat can be helpful to reduce the diarrhea that's associated with meals. So between the antidiarrheals, sometimes crushed, like if you have a little pill crusher that increases the absorption of it because it's all crushed up and everything, especially for people who have rapid transit. Sometimes I swear those little Imodium capsules are gone from the system before they've even been absorbed. So that can be helpful and really has been a game changer for a lot of my patients, something like that. And just having the antidiarrheal 20 to 30 minutes before you eat, avoiding drinking fluids during the meal, and then just maintaining hydration by sort of sipping over the day. You can get in a little bit more fluids that way. One other thing I should just mention with the oral rehydration solutions, because people are going to think I'm a total quack when they try it, because it does taste like seawater initially. Like the drip drop was probably one of the most tolerable flavors, but there's other ones too. There's ones that are put out by the same makers as tube feeds and things like that as well, that you can get over the counter. And you can also make your own packets as well and add flavoring drops. And so usually it's just like, okay, start out with just a little bit, cold. And it is an acquired taste. So, my patients who don't really have any other choice but to drink these because they're missing the gut that they need, it takes probably about 3 months to sort of acquire the taste. It's kind of like if people remember the first time they tried coffee and it was so bitter, but then, over time, it's kind of like a learned taste as well.
And then we get addicted. Yeah.
So, right.
No, I think that little pointer that you said about drinking it cold too, I've heard, and I've actually tasted some myself, that they do taste better cold. So that's a really nice little pearl as well. Yeah. I'm glad you brought up the oral rehydration solutions because a lot of times the focus is so much on medications. What do I take to stop this diarrhea? That's a really good point that there's things we can drink to help it as well. And that's another way to combat it. Okay.
Yeah. I know. And
really,
just the one thing on that is, sorry, just to make sure that, when you, like, say you buy those little sleeves that you just add water to, like liquid IV or drip drop or whatever, you just need to make sure that you're adding the exact amount of water that they recommend. And that's because it's actually the concentration and the ratio of the sugar and the salt in there that optimizes the absorption of water with these things. And so if it's off, they just don't work as well.
Right. Okay. So related to this, this person mentioned that soups and cereals have more liquid than other foods, but he's advised, or he or she is advised against drinking fluids with meals. Are these foods bad for the diarrhea problem? So I know you kind of touched on this.
Yeah. I know. Well, and especially people who need like the more blenderized consistencies and all of that stuff. I find often the soups and things are fine. You just need to sip them as you would, liquids. So, it's just, instead of like just gulping it all down, although most people don't do soup that way anyway, you should be fine as long as it's being consumed over a reasonable period of time. This is the concept of sort of like the soup and especially cereals, because there's starch in there. Those are going to help usually bind some of the water too. So as they're going through your digestive system, they're binding a little bit more of the fluid as well, the soluble fiber aspect.
Got it. Okay. I just have two really do that. Okay. There's a couple like really quick last questions. So this person mentions that there's melatonin. There's studies at the NIH that serotonin and melatonin share some of the same receptors in the gut, and is wondering why this is not a recommendation to take melatonin for serotonin-related diarrhea.
Ooh. To be honest, that is a question I do not know the answer to. I actually have never thought of that. So probably because I haven't used, we use melatonin for sleep enhancement, but I actually have never looked into that before. future study maybe for somebody.
Yeah, future study. And
Yeah.
one last question is, what natural therapy can be offered to patients currently taking Sandostatin LAR but develops hyperglycemia?
Oh, this may be a little bit trickier, right? So, yeah, sometimes people do get the hyperglycemia with the sandostatin. Then I would actually start with a registered dietitian. And doing your carb counting. You want carbs that are combined with other foods to sort of lower the glycemic index and absorption of them. So having sort of mixed meals, and then also with sufficient fiber too. That's going to really end up being your strategy there as far as like a most natural kind of therapy.
Great. Okay. So I guess the takeaway from all this, because you mentioned, working with a GI dietitian, I know you've shared that you work with the surgeon and the oncologist, is really working with a multidisciplinary team. So
yeah, I think so. Mm-hmm.
Yeah. So we really thank you for being part of that multidisciplinary team and really helping all of us in the community. And now, I mean, you've been so generous with your time with this really thorough presentation and the Q&A. I have to admit, I Google searched you, and some of the reviews I saw were that you're very knowledgeable, thorough, and caring. And I would have to agree with that.
That's nice.
So we just thank you, Dr. Paski, on behalf of the whole of LACNETS and the whole NET community. Thank you so much, and we hope to see you again soon.
Yeah, thank you so much for having me. I really appreciate it. Thanks.
Okay, great. Bye.
Yeah.
Thank you, Dr. Paski and Lisa. As a reminder, today's webinar is being recorded, and you can view the webinar on our YouTube channel within the next week. You can rewatch, pause the slides, and take the time you need with it. Also, we'll be sending a post-webinar survey that it would be greatly appreciated if you took 3 to 5 minutes to do. Thanks to our incredible donors and supporters, LACNETS is fortunate enough to be able to offer our programs at no cost to our amazing community. As we continue to grow, our supporters and donors would like to frequently hear from you and your hopefully positive feedback and constructive suggestions. It's a really easy way to give back, support LACNETS, and help us improve our programs. So we'd greatly appreciate if you were able to take the post-webinar survey. Now off to you, Lisa.
Thank you, all of you, for joining us today. Thanks to Dr. Paski and Rich from TVP Live. And we hope that you can join us again for one of our virtual support group meetings and for our upcoming NET Cancer Day Symposium on November 7th. See you next time.